introduce Dr. Shnyra. He received his BS in Biophysics and MD from Pirogov Medical Institute in Moscow, USSR. He went on to receive his PhD in Biochemistry at All-Union Cardiology Research Center at the Academy of Medical Sciences in Moscow as well. He is a worldly traveler, having worked in the USSR, Sweden, and the United Arab Emirates before coming to the middle of the map, USA's Kansas. He started to work at the University of Kansas Medical Center and UMKC before joining KCU in 2007. Dr. Shnyra was awarded an NIAID grant of over $1 million to work over a 5-year period on his proposal titled LPS-Directed Macrophage Innate Responses to Infection. During which time he mentored undergraduates, advised master's and PhD graduate students, and supervised numerous postdoctoral fellows. His work has produced a plethora of publications in both peer-reviewed scientific journals and books. He has been cited more than 893 times in scientific literature. Currently, in his lab at KCU, he's exploring several avenues of immune modulation and reprogramming of tumor-associated macrophages, and is a professor in our Department of Pharmacology and Microbiology. He's been an intent listener and active participant in our COVID-19 Journal Club series, where his engagement and expertise in the area of virology, microbiology, and the immune response has been incremental in student learning and engagement. We're honored to have him participate in the MKRC Seminar Series now and give his talk entitled An Unorthodox View on the Alzheimer's Pandemic, Are Statins to Blame? I will turn it over to you, Dr. Shnyra. Please, everybody mute your mics, and if you have any questions, raise your hands and we'll moderate them in. Thank you.
Thank you, Shelley. I'm flattered, right? So, but let's start because we're already 7 minutes over. I will put it here and share, right? And let me go, right? So it's actually this history for this lecture. Our students, KCU MD students had a chapter of medical students of Missouri. They had a Missouri meeting in our school, and they asked me, can you prepare something which will be educational for us? And I decided, why not to do it? All right, so, and that's how it came later with this particular title. But let me begin, of course, because it's relevant to clinics, I have to do a conflict of interest. So that is not me. So I have no interest in anything what I will be telling and discussing with you. Right, so learning objectives. This is always for me difficult because when I teach medical students, I don't teach them learning objectives. I teach them simply think and use the knowledge for there. So therefore, I second these words was said by Socrates. And so it's probably too much, but at least I'm trying to make my students thinking more than just memorizing what is given to them. Now, with this old small preamble, let me go and talk about what the topic of today's presentation. All right, so I decided for that student's presentation, talk about evidence-based medicine, because many of them receiving their scores, particularly from USMLE, and after that, somewhere I've seen it all the time, they are evaluated whether do they know evidence-based medicine or not, and I was wonder how they do it and decided to teach them because many of them not exactly know what evidence-based medicine is. So of course, the best way is to start with the definition. Evidence-based medicine is the consensus, explicit, judicious, etc., etc., etc. Right? So which help you make decision about care of individual patient. So with this particular start, I would like to apply this evidence-based study for statins and their role in pandemic, Alzheimer's disease pandemic. So actually that is what happened at about 2015 or 2016. That's where they suddenly announced that by year 2050, we have almost 14% of population, elderly population, will suffer from Alzheimer's disease. And I look at that and I said, what is this? Why it is so quickly and such a drastic rise in the rate of this disease? And of course, before starting this, we need to look whether this disease is genetic or complex. So let's look at the determination of genetic disease. Look, if we talk today about cholesterol, that will be familiar hypercholesterolemia. That is what is autosomal dominant disorder. You have that gene, whom that is 100% you will have this problem. This disease associated with the problem with LDL receptor. So that is a genetic disease. What is complex disease? Of course, genetics play a role, absolutely important. But after that, for the complex disease, also important lifestyle and also important environment. And that is what complex disease. So now we need to define whether our Alzheimer's disease is a complex disease or just pure genetic disorder. How to do it? We come here, right? So that is showing you that on the overlapping the development of disease, the highest when all of these three criteria kind of coincide, overlapping each other. That's the highest risk to develop disease. Now let's go how we study. So what is Alzheimer's disease? Is it complex disease? How do we know? That is coming from the studies which using so twin studies, so called. Twin studies is determining whether what the concordance rate. Concordance rate again between identical man, identical woman, non-identical man. It means non-identical. That is a twins, of course, non-identical twins, and non-identical woman. That is particular publication. All right. So why studies made in, I believe, in Sweden. All right. So and it's showing you here, particularly at the end, we're talking about Alzheimer's disease. And now what is here showing that when you have identical men with this disease, if one of the brothers, identical brother, has Alzheimer's disease, there is a 35% risk that another will have it. So now what we look here for genetic disease, that is absolutely dependent only on the gene, 100% will have, as we discussed, familiar hypercholesterolemia. So this one indicating that in addition to genes, something else playing a role. Now, indirectly showing you that non-identical men should be less than identical, and it's clearly showing that it's now only 20%, about 20% risk to have this Alzheimer's disease if one has and another at risk to have it. So for female patients, unfortunately, it's higher, and it is about 60% concordance rate. For identical twins and non-identical twins, 41. So that is clearly indicating if it's not 100% concordance rate, it's not genetic disease, it is a complex disease. And now, conclusion, we have it here. Yes, Alzheimer's disease is a complex disease where genetics, lifestyle, environmental play a role. Now, we're coming back to this particular graph. And now look at this one, genetics. What is leading, let's look, what causing this rise? If we're discussing about genetics and look at the time frame, that is too short for any genetic changes, meaningful genetic changes. And to prove it is very simple. Many of our students still use the Gray's anatomy, which was published in 1856. And we're still the same. All our muscles are the same, all bones the same, everything is the same. So that is not genetics. Within that interval, we consider when in 30 years, drastically increased rate of Alzheimer's disease. So What I decided to do first, when I've seen this paper, go and collected statistics, age-adjusted Alzheimer disease death rate in the United States. And I came to this presentation, all right? So there are two rises here, a very sharp rise, and a rise here also occurring. So it looks not very high, but if you increase the change the diagram, and here you immediately see that there is a substantial increase. So you're thinking about maybe at the beginning of this 1979, so Alzheimer's disease, relatively new one, and there was no criteria to develop it. Maybe this is reflecting. No, it actually was introduced specifically in the 1989. What's the criteria for diagnosing Alzheimer's disease? And that's maybe where we have uptick the number of diagnoses. All right, so, but what is here? Why we have here such a significant increase? That is remaining a mystery, right? At least for many of you LPS students, probably your parents were not even born when I will be talking about 79. So let's take this graph and bring it on another slide. So what is specific at that time happening? I was in year 4 medical school at that time when seminal work by Brown and Goldstein appeared in the analytical reviews Biochemistry. That is what actually identified cholesterol as the major part of atherosclerosis process. So after that, later, what is appeared? In 1984, Issue magazine also blamed cholesterol for developing of atherosclerosis. And all the story ended up here with awarding Nobel Prize for the Brown and Goldstein received this Nobel Prize. Now, how it is overlaid with our understanding that Alzheimer's disease is a complex disease. So genetics, we decided, could not change it too early. So here we have that life changed. Low cholesterol diet was introduced from now on. All right, that is interesting. That was quite interesting. But let's go and look what's happening here. We're still with the age-adjusted death rate caused by Alzheimer's disease. And now I'd like to show you here a diagram. Sorry for the quality because I got it kind of pirated copy from it's reports, economical reports, which may cost about 3,000-5,000 about markets, etc. But somebody posted, and I stole this diagram for you. What is deliberately I made here? So you probably did not notice. I exactly stretched the ordinates matching 87 and 2011. So they are absolutely identical on this one. And after that, if we look at this, we immediately can see with you that the uptick in the sales went about 98 when we have the core, Lipitor period, etc. But let me move something around here. Did you notice? That is exactly when we have this absolutely unexplained increase in the death rate from Alzheimer's disease. Now, considering here, we have of course, that is circumstantial evidence that it coincides with the time when statin sales increased and started prescribed it very, very widely in the United States. So, talking about our case as a complex disease, again, we have here changes in lifestyle. Statins were introduced at this time. So, conclusion that circumstantial evidence suggests that introduction of low cholesterol diet And statins actually result in increased death rate caused by Alzheimer's disease. Now, let's proceed. It's all about cholesterol as we understand based on this one, but question remains. Is it good? Is it bad? Or it's ugly? I know officially it's ugly, but how much ugly? Let's us investigate together with that. So now cholesterol was defined as a risk factor for atherosclerosis. And that is what should be understood. There is a cutoff area, right? So this is the healthy people. And if you below this cutoff, you are protected from disease. If it's here, you above some concentration of cholesterol, that's we will have cholesterol disease, right? So heart disease. Now, let's look how it is in reality works. So I take here a specific study, which Framingham study. Clinicians know that is a very, very reputable source of information. So these studies produced by this group try to identify risk factor for heart disease. And look what is very important. It was published 10 years before the first statin was introduced. So it wasn't affected by big pharma. It was just stating what they found. Let's look what they found. So this is what supposed to be, not if it risk factor, cholesterol, but I will overlay here exactly the cutoff from that publication. And you now can see here telling you that coronary heart disease, so people without disease, 219, all right? So here, and people with coronary heart disease, actually, it's not so clear-cut how you come to conclusion that cholesterol is the risk factor based on this study, and study done on huge number of patients. Let's proceed our investigation from now on. Before we go in, I will be just asking you one particular question. Based on this Framingham study, is cholesterol a reliable risk factor? I'm not saying that it is reliable or not. I leave it to you to decide. Because we're evidence-based medicine study with you now. All right, let's proceed. Let's see how cholesterol levels. I went next and I started thinking, okay, if it's high level, it should be, of course, the risk of death. And I went for these studies and I found this study here, published in Circulation, which is a very reputable publication for American Heart Association. Very nice. So what is they did? They actually review and discuss the existing data on U-shaped relationship between mortality rates and blood total cholesterol levels. And that was published in 1990. So let's look what the findings of that particular, what made them so interesting. Because I like it because it is 500,000 men and about 125,000 women in the United States, Europe, Israel, and Japan was kind of analyzed here. Let's look the results, what the results were here. That is very interesting. You probably never saw that this exists. So let's look first, relative risk of death for men, what we have here. That is what relative risk of cardiovascular death. We can see here with the increase above 2,200, so there is increased risk of death caused by cardiovascular disease. Now let's look at another table. What was present? A relative risk of death, total cancer. Here it's reverse relationship. Actually, cholesterol is protecting. And the high level of cholesterol actually reducing the risk of cancer, in this death of cancer. Now here it's another. If we take all of them and subtract all right, so leaving non-cardiovascular and non-cancer here, that is amazing how cholesterol actually reduces the death. Now, if we combine all these three graphs together, we have here this one. So at low concentration of cholesterol, you have increased risk of anything, right? So, but cardiovascular death. And here is increase again at higher, you have an increased risk of cardiovascular disease. But this one, which is attracting me and talking. And so here, of course, based on this data, just answer this question. Are normal to moderate elevated levels of total cholesterol associated with reduced relatively death rate of all causes in men? Yes. Yes. Let's proceed and see for female patient. It's even more obvious, right? So this is, I don't explain you here because it's repeating the same. This is a cardiovascular, this is a cancer, this is all non-cardiovascular, non-cancer. So taken together, that will be for female. There's no reason to take because they just lowering cholesterol, they increase their risk to have a death. Interesting, isn't it? Now, again, I'm not saying what I think about. I ask you a question based on this report. What your conclusion making about? All right, let's proceed. After that, I decide, let's go and look how it is associated with heart attack. You will be surprised, this study. Study here is taken and they are published in American Heart Journal, right? So, and it is very important because it's assembled a big cohort of people who was having a documented lipid levels in the first 24 hours of admission. Very important. Now let's look what the results are here appear. You will be surprised. If we have here a patients with cardiac disease, so 72% of them had concentration less than 130. Among people with cardiovascular disease, here we have 50 of them had less than 100. 18% even level 70. And they still had attack. Interesting, right? So let's see here. And that is for individuals with, so interesting data. So the conclusion, only 1 in 4 patients hospitalized in the United States with heart attack had cholesterol level more than 130. Interesting. Interesting. So, again, is cholesterol a risk factor for heart attack? Answer yourself for this question based on evidence provided. All right, now, end of the low-fat diet recommendation. You remember that from the beginning in the early 80s, that's where cholesterol was blamed for everything, and cholesterol low diet was introduced. But after accumulation, all of this within, let's say, 80, we have about 30 years of study. Now, NIH considered no nutritional concern. Dietary cholesterol is not a problem. Technically, we're a little bit ahead. Only 25% of cholesterol come with food. So now 75 cholesterol sensitized in the body. So we don't worry about dietary consumption anymore. All right, so but That is what not highly publicized, but this is in 2015 occurred. Now, as always, it's a very, very big report, and only on some page 75 or 76 there was this particular statement. All right, but anyway, it's a huge statement. Now let's see how introduction of statin affected the mortality of disease. Now, that is what I was found, this particular death rate in the United States, so which is associated with heart disease. And you can see here, it's steadily declining in all population of white men, white women, black men, black women, all steadily decline with improving of healthcare, etc. So now what is here? That's the time specifically pointed here for you. That's the time for introduction of statins. Now, I specifically blocked what's happening after 1987 for you, because statins were introduced here. What anyone anticipated if it's wonder drug? That will be like that. That will reduce the death. Now, let's reveal what is there, which is hidden for the block, under the block. It didn't affect at all. It's continued at the same rate, like there are no statins. Surprised? I was also very surprised why it didn't change, as it claimed everywhere. All right, so again, rhetorical question. I'm avoiding any liabilities that I claim something. I ask you to make a decision and making your answer. All right, let's proceed. So all of these studies, I have a little bit problem with them. They are always sponsored. And after that, they use relative risk, which I will discuss with you, versus absolute risk. That's how we will explain. And after that, combine it, clinical endpoint instead of mortality. That's all kind of create scientific looking information and put insignificant findings, highlighting them. That's to explain how it is happening. First of all, that is what I would like to remind, that there was a prime minister, British Prime Minister, Benjamin Disraeli, who said once that 3 kind of lies. One lies, another then it lies, and statistics. That is what very, very interesting, right? So if we consider the case of statins. Now, relative risk reduction, absolute reduction, and look, on the top of that, tips for learners of evidence-based medicine. I found it just because of name, right? So it's very interesting here. All right, now, what we have here, relative risk. So you have an event rate in intervention group, that is a statin, right? And you divided event rate in the control group, which were not given statins. But absolutely, it's actually difference percentage between intervention group and control group. Guess which risk actually shown you when they discuss atherosclerosis and effect of statins? I bet relative risk. Now, I will be using this particular publication, so which published recently in 2015, how statistic deception create the appearance that statins are safe and effective, particularly from this publication. Look at here. What is interesting? Oh no, I don't have it here. So we have a placebo group, 97%, right? So, and here with statin group, 98. So what you have here, if you subtract from here, so from 98 minus 97, you have 1%. So, but now look what's happening. If you take and divide, so relative risk here, 1.1 divided to 3%, so you get 36% relative. 1 is absolute and 36 relative risk. I mean, if I would like to prove something, relative risk will be much better because, oh, it looks like it is 30%, less than more. It has nothing to do to absolute risk. That's unfortunately used all the time instead of absolute risk, which is only 1%. All right, that is what a big difference, as you can see here. So, if you take statins, you have reduction of your risk 50%, and that's every primary physician tells you. I just in very good relationship with my primary physician, and I ask her, what does it mean? How they cannot explain it, why, and what it means relative. But now you know, and simply is saying, look, if something very small, you divide by, if something's small and you divide it by very small, you will get a huge number. You agree with me? Yes. That's how this is relative risk is calculated, unfortunately. All right, let's go. Now, after that, appeared research and published it actually in 2013. So that is a study come from, I believe, University of Oxford. So they're saying that a statin a day keeps a doctor away. That's what they call it. Because they're saying that is what the findings of this, right? So that 9,400 lives will be saved in the United States, or in Britain, in Britain. If patients over 58 will took daily one study. What is interesting, another study shown very interesting. Look at this one. In the same, they show that 8,500 lives will be saved if every citizen will eat an apple a day. Oh my gosh. So I'm okay with statins if there is no track of serious side effects with these drugs. All right, let's proceed from here. Now, are statins safe? That's always a question, right? So, which are absolutely differently considered, depends who you are. From the beginning, the voices were raised. That is publication in 1991. After those people were silenced. There is no now complaining about that adverse effect of statins, right? So it's so often seen in all clinical trials, they are underreported. Now nobody goes so far, 91. It's too long ago. It's maybe not even, somebody will claim it's not scientifically solid or information, but that is a reasonable concern. And after that, this is what I published it, and I found that University of San Francisco analysis revealed that 96% of authors with drug company ties declare statin to be safe, versus only 37 authors with no ties. Let us give you a shot how those big pharma may affect the results, and I did not make it. This is the citation from this publication. All right, statin, risk versus benefits. And so are statins really wonder drugs? And that is all the time what we measure. In any medical approach, we measure risk and we select the right decision based on our estimation benefits and risk. And so what benefits of statins? That's what I put here a question mark, because it doesn't look that it is giving better anything than just simple apple a day. Now, but also every practitioner knows what the list of abnormalities associated with use of statins. It's incredible how this is drug causing so side effects allowed to be on the market. But even no, look about it. If we take any antibiotic, new antibiotic, and after that it's marketed saying, if we take 100 people who get infected, our antibiotic will save one of them. That will be wonder drug? No, nobody permitted. But here we're saying about that it is only 1% difference in risk. And it's called wonder drug. All right, so sorry for that lyrical tone, but everybody knows about these side effects. Now we need to consider here, it's not Alzheimer's disease here, but I think that's what I would like with you to discuss with you, why it is also affiliated with Alzheimer's disease. All right, here, that's for you. One question again, just to make your decision about what you've seen, just highlighting. All right, hopefully you had enough time. Let's proceed. Do safe alternatives of statins exist? Oh, that is not anecdotal, but they do exist. And I like the statistics. And I think many of you will be liking it. So this is taken from publication of Journal of the American College of Cardiology, 2010, alcohol consumption and cardiovascular mortality in this. So this is a non-drinkers. And after that, there are light drinkers, moderate drinkers, heavy drinkers, and here different pathologies, right? So different pathologies now, including coronary heart diseases. Now look at this one, coronary mortality. It's taken if you're non-drinker, taken as a healthy cohort. So now if you're light drinker, look here. Oh my gosh, it's such a reduction. So it's a little bit danger zone, but moderate even better. So don't go heavy because benefits are cancelled at this one. So moderate, light, moderate drinking showing here some kind of improvement in coronary mortality, and that is published data. Now, what we have here, mortality. So we talk about stroke mortality. Look at this one. It could be reduced 25% if you are moderate alcohol consumer. I'm not advocating, I'm just showing you so what available data is. Now, let's proceed further with all of these findings. So, do you know that there is a company, Nymex Pharmaceutical Corporation, that holds patent rights on statins for treatment of Alzheimer's disease? Surprisingly, yes, but this is what is existing. They have a patent for that. Of course, if you have a patent for that, I'm likely that it's not patent yet for oxygen, what we take every day, every minute, but this is already patented. If you will use them for treatment of Alzheimer's disease, you have to pay royalties. Interesting. Why they decided to go? So the holy grail of this particular Alzheimer's disease and statin is the following research. I'll show you. All right, so, and that is what conclusion is here. So they conclude that total cholesterol level was associated with increased risk of Alzheimer's disease. Even moderately elevated cholesterol increased dementia risk. So need to be addressed as early as midlife. All right, very interesting. But let's look. So this paper, of course, made this company holding so patent very happy. But I just look and read that paper more specifically, and particularly took one of that studies and compare statistics which is presented there. Now, again, what is happening here? The mean value for Alzheimer patients, so that was 228.5. So measured in milligram, not deciliter cholesterol. People who know dementia, 224. Oh, really? Okay. Now I look at the material and methods, and I found test what they were using for determining cholesterol level, and I was wondering how accurate that test. So for this study, it is showing that the difference between no dementia or healthy and Alzheimer's disease patient just 2%. All right, so how correct this is it? And I found this publication. In this publication in particular, they took 2 standard samples using the same kit as the study used. And they took 2 concentration, one concentration 102 and another 292 milligram per deciliter of cholesterol. And after that, they repeated in 30 replicates of each standard. And after that, that's what they found. The error is showing here. This is a table from this publication. All right, so that the difference is standard deviation is 2.4%. Now remember, right? So that is what we have here. But in this one, we have difference only 2%. So you cannot measure with that assay accuracy and claim that patients with dementia have high concentration of cholesterol. That just sounds absolutely ridiculous to claim. All right, let's proceed it here. All right, so versus that is not working. I'm just showing you here. All right, so again, error 2.4, difference less than 2%. How come, guys? All right, let's proceed it here. However, despite the major findings supporting potential use statin for Alzheimer's disease, FDA has updated in 2012 recommendation for statin in order to reduce the risk of cognitive adverse effects. So already by 2012, there were pilot complaints as an adverse effect on cognitive function of the patient who is taking them. Now, here, that is all particular. I highlighted here everything what is said here. So, and describing the usual ratio and extremes, but what I would like to say here, not so much specifically what they say, but tell you that actually there is already concern about cognitive function. And there are cases which is now presented on the online magazines, etc., which actually done by physicians themselves. I will not talk about it. So let's talk about cholesterol in the central nervous system, because I have to finish it at some point here. Now, let's come. What is interesting about it? That is what paper, which is a Amber report saying about it, 2014, exactly cholesterol in brain disease. Here, I have some information to show you. That is, first of all, showing you that cholesterol in the brain, right? So it is sensitized in the brain, right? So it is not allowed to enter. So from circulation, that is very important. All right, here, there is a block for cholesterol. So the blood-brain barrier is not allow cholesterol penetration. So here, cholesterol is needed, of course, because that is what oligodendrocytes are required, absolutely. Right, so brain cells are cut off from the blood supply. But what is interesting is drugs, statins, at least some of them, most of them, I would say, most of them are freely penetrate inside of the brain and can inhibit autonomous synthesis of cholesterol in the brain, which is so important for that. Now, insert role of cholesterol in central nervous system. It's very important here to say that half-life of brain cholesterol in adult organism between 6 months and 5 years. So every 5 years, it is substituted at least. Now, in humans, more than 95% of cholesterol is produced de novo in the brain. Now, that is very interesting. And now with statins, we come in and interfering with that. That, of course, will have consequences. Why I'm thinking about these consequences, of course, I explain you. So if you have a problem here, all right, so, and shelf is not produced, of course, it's like you're trying to connect electric cables which do not have insulation, and you will have, of course, shock. There is no question about it. Right, so therefore it is absolutely required. Right, so, and that is actually normal. It goes on unless we are interfering by consuming statins. Statins are freely, most of them. There are only 2 on the market which are hydrophilic or hydrophobic, and others are hydrophilic, and they are all so goes there easily. Now, this is what another example for you. Upper ear play an enormous role here, and I found this very interesting publication. Right, so what relationship between cholesterol and Alzheimer's disease? So, exemplified a number of rare diseases, primary diseases, mutations in cholesterol-related genes. I know that even physicians, many of them never even heard of these so rare genetic diseases, but I had time to collect them and present for you. Desmosterolosis. Now, I highlighted here for you. So affected the pathway of cholesterol synthesis, but no, was linked to development of Alzheimer's disease. Now, something interfered with cholesterol synthesis result in Alzheimer's disease. That is a naturally occurring mutation. Now, what we have another one, Smith-Lemli-Optic syndrome, intellectual disability, which is related to mutation enzyme catalyzing the life step, etc., of cholesterol biosynthesis, result in reduced brain cholesterol, usually low cholesterol content in the brain. So, and now it's intellectual disability. Now, it's not only one, there is a Rett syndrome. So again, cognitive disabilities, intellectual disabilities, autistic behavior, and again, linked to the gene involved in cholesterol synthesis. So now we consuming statins, we deliberately interfering with the synthesis of cholesterol in the brain, which is exemplified already by, that is so important, by these syndromes, which I discussed with you, which all affect cognitive functioning of the people. Now, we have a couple of, right, so one more here, progressive dementia, right, so when we have some enzyme which is controlling exit of cholesterol from the endosomal lysosomal system. Gosh, all of them with cholesterol. So mutations linked to cholesterol pathway in the brain selectively. Now, an APA, that is very important finding. It's highlighted here. So that if you have a deficiency, so APA here, cholesterol carrier that support lipid transport and injury repair in the brain. So what is found here is that if there is a mutation, so in this APA protein, so it is increasing risk of Alzheimer's disease. Again, of course, circumstantial, but indicating everything what is affected with the synthesis, delivery, that's of cholesterol in the brain affected, in some cases as this one, increasing risk of Alzheimer's disease. So now, if you have just one copy of that mutated APA, so you have increased 2 to 3 times. If you have 2 not more normal functional copies, A4, increase it 12 times. Indirectly pointing that cholesterol is important in the pathogenesis. Actually, deficiency in cholesterol is important for developing of Alzheimer's disease. All right, here, that is all what we use here. They have different properties. And now I would like to kind of give at least some positive perspective for this one. So here is labeled here, lipophilic, 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 lipophilic. Those ones are easily can be accumulated in the brain, where they will stop local synthesis of cholesterol, which is, as you know, 95% depend from local production, and actually it is half-life about 6 to 5 years in the human. So that is quite intensive. So hydrophobic, which are here, that is another story. So lipophilic can penetrate and inhibit synthesis in the brain. And that is what probably will contribute to that image, which is projected how we anticipate an increase in rate of Alzheimer's disease in 30 years to come. But hydrophilic is actually the one which are not going in the brain. At least if you prescribe it and you do not have guts to stop using statins, please take prescription of hydrophilic. So their bioavailability in the brain is low than normal, and you can produce less harm for those people who is taking statins. I'm already about 3 minutes before an hour. We started a little bit later, and I'm open for any questions or discussion or any concerns with this investigation, or maybe your particular take on this, and I will be very happy to talk with you. All right.
Any questions for our speaker? Dr. Talley, go ahead.
Okay.
Dr. Talley, did I see your hand up?
No, that
Error, I apologize.
Oh, okay. Any questions for our speaker? If not, going once. Ms. Turner.
Sorry, I'm sorry. I think I'm unmuted now, so you can hear me.
Yes.
Good afternoon. I wanted to say thank you so very much for this presentation. I've been struggling with cholesterol issues of my own, and right now I have just started the journey with my mother-in-law who is suffering from Alzheimer's disease and who's been taking statins for some time. So I'm overwhelmed with information and really enjoyed the presentation today. I guess my question for you is this: how does calcium play into cholesterol storage, and does it affect the overall number of cholesterol, and how does the statin work with that number? As strange as this sounds, my personal story is that my cholesterol was at 230. My doctor wanted to be very aggressive with a statin. Because I've done my research and I agree with what you're telling me in the study, this is the same information I basically found out. So my argument back to her is that I wasn't comfortable taking the statin that she was recommending. So she asked to have a calcium heart scan done. And on a scale of 1 to 1,000, it was 24. They don't even concern themselves with the calcium until it's over 300. But I've been on a statin for some time, and I've had to work my way back from atorvastatin and Lipitor. I'm all the way down to pravastatin, which is hydrofolic, and I love it. It works. It's doing what I need it to do as far as my blood calcium, and I'm very relieved to know that the blood-brain barrier is in place and it's not being harmed. So how does the calcium play into it? Because atherosclerosis is part of your conversation today as well. Thanks.
Okay, Bonnie, thank you so much. So for your information about your mother and yourself, I can only guess that because you didn't consume exceeded amounts of calcium as a supplement, that is coming from the body's only because of osteoporosis, right? So. And after that, they give you another drug that corrects this problem. And that's what happens when you have introducing one drug, it's caused a problem. You introduce another one to correct that problem. And it's a chain reaction. You never stop to do it, unfortunately. All right, so you need to make your decision. Nobody gives you exactly can say that take this one, not take it, but the best way is just to make your decision based on available scientific information. So calcium, how it is linked to statins, I don't know how it is actually causing the release of calcium from the bone. I did not go, I'm not pharmacologist, honestly, I'm immunologist. All right, so, and maybe somebody here who knows how they're interfering with calcium metabolism in the body, but I truly, Bonnie, I wish I can answer you, but I'm expert in another thing. All right,
so I have a quick comment. The role of calcium is it controls everything. So in graduate school, that's what a very fine professor told me once, and so I don't know that it's absolutely clear if or even how, but I can assure you that it is.
We need Dr. Zedi to answer this.
we need Zedi.
She's the expert in calcium.
She'll tell you the same thing. Calcium controls everything. Dr. Dobson, go ahead. You have your hand raised. Go ahead.
Hey, Dr. Shnyra, thanks for that great presentation. One of your very early slides talked about the global effect of statins, and you correlated it with death rate. You showed that huge increase in about 89 or 90. Was the death rate U.S. death rate, or was that global death rate as well? Were the same apples to apples kind of comparison, so to speak?
John, that's all statistics I was able to find in different states about deaths related to Alzheimer's disease. And they were fragmented. One was given you from 70s to 90s, another up and in between. So that is not what could be continuously found. But I assemble it, and I think all of them, even it was sources on the website of states, it was a national statistics. It's all about US, not other countries involved.
Thanks, Alex.
You're welcome, John.
Dr. Sarsour, your hand is up. Go ahead.
Okay, so I would like to thank Dr. Shnyra for this really nice presentation, and I would like to add to what he presented that, you know, the whole fiasco of lipids and cholesterol metabolism started with the Alzheimer's disease, the discovery of the mutated allele of apolipoprotein E and the allele 4, right? So it started there, and people just picked it up and assuming it's really totally had to do with cholesterol metabolism. The reality is, and the evidence now, there is a lot of publication showing how ApoE actually have like three main mechanisms that it can contribute to the development of the Alzheimer's disease. The first one is its ability, because it's a mutated form, to bind to the amyloid beta and create these aggregates. The other one is more of immunological, by, you know, suppressing usually ApoE with the lipoprotein receptor that it binds to it, usually have anti-inflammatory properties. The problem is when you lose that and the aggregates of beta sheet, you create a more pro-inflammatory environment. The third one is a metabolic modification, and a lot of people did PET imaging, positron emission tomography, using FDG, the fluorinated deoxyglucose, and show a decreased metabolism in the brain with patients with AD. And it's contributed that what happened is these aggregates from ApoE and the amyloid can create something like plaques and you know, block that blood supply to the brain and affects its metabolism. So these are, you know, so I think the whole fiasco that, you know, people say, oh, let's use statins to block that. This is why, because it's failed, because it's not really targeting the real you know, real reason here. Yeah, it's related to lipid lipid metabolism and cholesterol metabolism with the ApoE, but it's not really targeting ApoE.
Yep, it could be candid explanation, but you name it. All right, so exactly. And I tell you what, if you have several explanations, nobody knows how it works, right? So that's why we have several explanations for that.
Yeah.
It's a very nice insight. Also, in my presentation, API immunodeficiency, not immunodeficiency, I was teaching immunodeficiency at this point. So, but deficiency is exactly part of this, indicating, again, circumstantial. All right, so I did not try to bring and say this is exactly, but those pathologies which are manifested as a development of dementia, all right, so they are all related to cholesterol, local synthesis of cholesterol in the brain.
Yeah.
And after that, maybe cholesterol prevents aggregation or something like this. That might be many things, and I'm not expert to tell you. It was my investigation when I made it. I have a very strong case to say my physician when she says, Alex, we need to prescribe you 220. I said, no, I take educated decision. I'm not taking statins. And that's it. Right,
so I have a quick comment for you guys, and I put a link in the chat that'll clarify some things. So I actually was a postdoc at GlaxoSmithKline when the ApoE4 guru who tied ApoE4 to Alzheimer's disease, his name was Alan Roses. So he was the CSO, Chief Scientific Officer at Glaxo, and he came into power at Glaxo when I was a postdoc there. So ironically, he died of a heart attack, and the link I put in the chat talks about that irony. He thinks at the end of his career, it wasn't ApoE4 so much as a gene right next door. ApoE4 came as a result of, SNPs and CHIPs, genome-wide association studies. That's how he got it. But it's actually a gene called TOM40 next door that at the end of his career, he thought that was the actual causative gene. It's a mitochondrial outer membrane protein. So it's kind of sad that Baki's not here. Okay. Any more? Yeah, we do. No, that's my hand. I'm sorry.
No, there was a hand of Bonnie, I think. Yeah.
Yeah.
Bonnie,
no. Did you have your hand up?
No, it just keeps putting a message on my screen that says your hand has been raised, but it's not green. So I'm not sure why it would show that it was up. So Thank you.
Dr. Dobson, I see your hand is up. Go ahead.
Yeah, I'll go for one more. Alex, you mentioned a bunch of rare syndromes that are associated with the development of dementia, but Down syndrome is also associated with an increased risk of dementia because the amyloid protein is on chromosome 21, and with trisomy of 21, those individuals have an increased risk. Now, they also have an increased risk of obesity. Did any of your studies come across statins in the population of obese Down syndrome patients and some cognitive?
It stopped short. I have other interest as well. All right, so but that was interesting to look at that too. So I believe that we have a lot of things. Maybe part of that, I hear you that might be part of that also obesity pandemics, which might be related to that. Would be interested to investigate.
It was your comment, Dr. Staudinger, about a chromosome or a gene in the ApoE4 situation. I wonder if there's some other combination of chromosomes, the presenilin chromosomes 1 and 14, chromosome 21. So I just was thinking there's got to be an interesting epigenetic component to this, as well as a genetic component. So it's very...
Yeah, it's likely multigenic, in my view. It's likely multigenic.
I would agree.
I agree with it too, completely.
Dr. Wolf, I see your hand is up. Go ahead. You're muted, Dr. Wolf.
I was curious to what extent cholesterol was going to be separated in your talk from the statins, whether you were going to point to the statins or the fact that the low cholesterol was what was causing things here. And so I really like the fact that you came back and that you were talking about the ability of the drugs to cross the blood-brain barrier and to what extent they might accumulate in there and things along those lines. So that then got me to thinking whether or not I've never looked at these clinical databases that various students go digging through, but are there databases out there that would actually show you people that have taken pravastatin and to be able to compare that to atorvastatin and to see what the incidence is of Alzheimer's in those populations of people?
Excellent question, Dennis. I tried, but at that time when I was writing this paper, I couldn't find any meaningful statistics or mentioning in this particular framework. Unfortunately not.
I agree. That is an excellent question.
Where the students get access to that data from. I mean, there are databases out there that somehow, maybe Bonnie knows it, somehow somebody gets access to data like that where perhaps that question's already been asked too, I suppose.
I know that our anatomy department has fellows, and they have access to that database where everything is described, and they are pulling different correlation studies from there. So probably they can go and look for specific classes of I was
Dr. Talley?
No, I'm not.
Tell me what databases you want, because Dr. O'Connor and I are working. We've got a list already, and we're going to purchase them and make them available to the students. So if you can find a specific database that might have that in it, tell me.
I see Robert Rogers has put something in the chat as well. KU's
Yeah, you mentioned the mitochondrial thing. Hopefully my children will stay quiet for a second. I'm home by myself today with them, and this is the first time they just had me. But there's a friend of mine at KU that's actually been studying, and I mean, I think they're probably done doing it really, but he had always had this hunch that statins would reduce your aerobic capacity. And it looks like that is definitely the case. And so they're teaming up with like the group that studies Alzheimer's disease there, that the statins are disrupting your kind of mitochondrial motor, and that might be one of the links to the Alzheimer's disease study. That's or story. So I was just putting that in there because, you know, if it's going to reduce your aerobic capacity, I know that you're very much into health and fitness, that another reason to not take a statin might be, you know, a little slower on the bike. No,
it's not only, it's muscle pain. On the saying, I said, listen, I have pain enough muscle pain. Forget about it, I will not take. So, and, you know, I have across the street a friend of mine who was on diet for whole 1 year. He did not eat anything in the morning, just porridge, like that. So, and he went to analyze after it. He came and said, Alex, damn, it did not change a fraction. It stays the same. Because if we talk about 75% cholesterol is produced in the body, my take reading all of this material, and I kind of understand that cholesterol is a indication that something wrong, kind of inflammation goes on in the body. Body produce more cholesterol to reduce, because cholesterol has anti-inflammatory effect. And so, but it is not completely justified, attributed to coronary disease, because this is what middle part of my presentation. If you take studies before that, before the era of statins, they're showing moderate levels are okay. So that's what my understanding. So you don't need to fight with actually, which does something positive in terms of blocking some. We're all with age, we are inflammatory prone, inflammation prone. So that is what my understanding, how it is coming. And but again, to take decision, it has to be a kind of personal decision based on your level of cholesterol, your family history, and I suggest take the drugs which are not going through the blood-brain barrier, and that will be at least safe path.
I think that's sound advice in my view, and I'll endeavor to follow such advice. Okay, if there's no more questions, what I want to do now is have everybody unmute and thank our speaker again.
All right, thank you.
Thank you, Dr. Shnyra. Take care, everybody. Have a great